I'm Dale Sherbeck, and welcome to the HQ, a CHA Learning and Healthcare Can podcast serial where we dive into healthcare issues and topics from the perspective of its people and discuss them with those that are leading in the health system. Together, we'll try to unpack these topics and learn what actions are being taken to innovatively solve them today. If you've been following along with the HQ the past few months, we're now well along in our exploration of what equity, diversity, and inclusion means, including what it means to several equity-deserving groups. But the conversation and journey is far from done. In many ways, I feel like we, and I myself, still have far to go. I hope you're learning with me as well. One of the areas we have yet to go deep on is that of racism itself. And part of the reason for that is that I've been waiting to have this conversation with today's guest. And yes, while we have heard the voices of some that are part of racialized groups, we haven't yet really discussed what is at play here and our respective roles in bringing about an end to racism in healthcare. And to quote from our guest, whom you will meet shortly, it really is a discussion about how the world is and how it should be, which for me is also another way of speaking truth as we seek to reconcile our culture from all the harm it has caused and continues to cause nationally, organizationally, and within our healthcare sector. So with that, I'm truly thrilled to be joined today by Dr. Gaynor Watson-Creed. For many who are active or leading on this topic, Gaynor and her work needs no introduction. That said, here's a short snippet of her bio. Gaynor is Associate Dean of Serving and Engaging Society for Dalhousie University's Faculty of Medicine and past chair of the Board of Engage Nova Scotia. She's a public health specialist physician with 17 years experience, having served as the former medical officer of health for the Halifax area and a deputy chief medical officer of health for Nova Scotia. She served as a member of the One Nova Scotia Coalition Economic Strategy Table in Nova Scotia and was recently a member of the Federal Task Force on Women in the Economy, co-chaired by Deputy Prime Minister Chrystia Freeland and Minister Mona Fortier, which completed its work in 2021. Dr. Watson-Creed has an MD from Dalhousie University, a Master of Science from the University of Guelph, and a Bachelor of Science from the University of Prince Edward Island, and an honorary doctorate from Acadia University. She also sits as a chair or member of several national population health councils and boards and is a passionate advocate for high-quality public health services in Canada. Hi, Gaynor, and welcome to the HQ.
Hi, Dale. It's really a pleasure to be here.
Yeah, I can't thank you enough for joining us today and sharing with us your exceptional knowledge and wisdom. So maybe we can kick it off here with sort of going to a couple of quotes and maybe as we can start with getting you to respond with your thoughts on the quote that I opened with from you yourself about, what does it mean when we talk about the difference between how the world is and how it should be?
Yeah, and that's me quoting Inez Nin, who's a 20th century author, and I believe she was quoting the Talmud in that quote that she uses in one of her books. And the quote is something like, "We don't see the world the way it is, we see it the way we are." And I love that quote when I'm reflecting on the questions around equity, diversity, and inclusion, because I feel like they are pointing to us that there is something about how we choose to see the world that is always framed by our own experiences of it. And our own experiences of the world may not be a complete or even accurate representation of the world the way it actually is. And the challenge, I think, for all of us is to see the world the way it actually is. And from an equity, diversity, and inclusion perspective, I think many of us find that when we truly sort of go to take those blinders off and actually see the world the way it is, not the way we necessarily want it to be or believe it is, it can be a really ugly and disturbing picture. And yet I think it's actually necessary for us to do that work of taking those blinders off and committing to seeing things the way they actually are, because once you can see them, you can engage with them. And if you can engage with them, then maybe you can change them, right? We can change them collectively. And so a lot of the work that I've been doing in the Faculty of Medicine has been in part uncovering what is this history of inequity that has been perpetuated in some ways by the profession of medicine. And sadly, we have been complicit in upholding forms of oppression. And so a lot of my work has been, sort of showing that to my colleagues and saying, look, there's something here we have to look at. We may not like it. We may wish it's not there, but that doesn't make it go away. And now that we know that that's there and that medicine as a practice has been built in many ways on the backs of those oppressions, now we have to do something about that. And what I'm finding is that once folks kind of right themselves from, the initial kind of reel of sort of recognizing that that's been at play, they then sort of arm themselves to disrupt things because they're left with a really uncomfortable kind of cognitive dissonance that they want to resolve. And so as painful as it is, I'm also finding my colleagues across the country now, as I engage in these conversations, to be really receptive to the conversation, which is fantastic to see.
That's that's great that the conversations are starting and that there's a receptiveness to that. So you've talked about sort of there's a little bit of a history in terms of that oppression and inequity sort of built within medicine and healthcare itself. Can you point to a couple of examples that sort of would help us to sort of see what that might look like? And maybe as a follow-up question, just, because you use the word oppression, and I suspect that contained within that is the concepts of power. So where does that get connected to medicine, and how does that play out in this?
So I might start with your second question first around, kind of what is that intersection between oppression and power? Because it's an excellent question and gets at the heart of why at Dalhousie University, we are taking an approach around anti-oppression. And when we first started doing this work intensively in 2020, like so many other organizations did in the advent of, sort of Black and Indigenous Lives Matter, we recognized that we wanted to tackle racism, but we also wanted to tackle other forms of discrimination. And certainly when we looked for language that described that intention, we went to the language of anti-discrimination initially, but recognized that it felt limited to us because a lot of what we found was in the literature from the profession of law, which speaks to, the need to make sure that you're not violating human rights. And that felt a little bit like a low bar to us, honestly. And so when we went looking further, we were reminded of the language of anti-oppression, which is language that is used in the practice of our colleagues in nursing and in social work, and has long been a tenet of those practices and those professions. And what I love about the framing around the orientation around anti-oppression is that it points to two things. One is it points to the reality that all of us live with multiple identities. Mm-hmm. And those identities confer, in some cases, power and privilege, and in other cases, they confer disadvantage. And it is the combination of those identities that ultimately determines where somebody might experience either of those things, privilege or disadvantage. And so, what I say to folks as an example is I hold at a minimum the identities of woman, Black woman, and physician. And when I walk into a room, I'm aware that folks may react to me on one, two, or all three of those identities. I can't necessarily disentangle in the moment which of my identities they're reacting to, but I'm aware that whatever comes out of that, the constellation of their reactions will determine the nature of the relationship I'm going to have with them. Mm-hmm. And so within that, there is this notion of power. And so this is the second thing that anti-oppression points to, is the idea that as you were dealing with those multiple identities, you need to be aware that they confer power in certain relationships, and how that power dynamic plays out and who is left at a disadvantage because of less power in the relationship is critical to understanding what needs to be done. Mm-hmm. And so in that respect, anti-oppression really speaks well to, the name oppression, speaks well to the ways in which power over continues to be the experience of so many of our populations, that others have power over them, right? And so that's why we've chosen that language at Dalhousie University's Faculty of Medicine. And then, with respect to your question around where medicine has been complicit in upholding oppression, I recently was treated to an introduction to a colleague of mine at University of Kentucky who does this same work that I do as an associate dean in the Faculty of Medicine there. And I have been, sort of reminding my colleagues that, certainly looking at racism as an example, this is a socially constructed idea, which means that it was invented, and it was invented for socio-political circles. And I am not a critical race theorist or a historian or a sociologist. So much of this I am gleaning from reading in those domains and from working with my colleagues who are experts in those fields and have been saying this for decades and decades. But it was my colleague in Kentucky who pointed out to me that not only is that true, but when the initial socio-political calls went out from world leaders in the 17 and 1800s to help bring forward scientific explanations for why colonialism and domination of certain groups should exist, it was physicians that answered that call. Mm-hmm. And when he said it to me, I sort of had a moment of, I'd never heard it framed. This was just, probably 8 weeks ago. And I thought, I've never heard it framed that way. And then I went looking at the literature again and realized, oh my gosh, he's absolutely right. Physicians were at the forefront of creating that social construct. And so that's, the 17 and 1800s, but even working it forward, I talked to my colleagues, we're all aware of the examples of Tuskegee and Henrietta Lacks and those startling examples. And there are so many others. I speak to my colleagues of the ways in which Black anger, and particularly anger from Black men during the civil rights movement in the 1960s, that anger was appropriate, but actually it had a psychiatric diagnosis assigned to it in the 1960s. It was called the protest psychosis.
Ouch.
Right? Yeah, as though there is something wrong with that level of anger over the extreme violations of human rights that were happening at that time. Take it even further forward, you can look at the calls that we are still hearing from Indigenous women about forced sterilization and the role the Canadian healthcare system has played in that. I do, on occasion, refer back to even the master's thesis of our beloved Tommy Douglas in this country. He was a hero of mine growing up in my house, and he wrote some theses in favor of eugenics when he was a master's student. Yeah, he rejected those ideas in the end, absolutely. But all of those components of our history are there. And then you look, even in modern times, at the numerous ways in which we hear about overt discrimination against patients, yes, from a variety of backgrounds, queer and trans community patients, BIPOC patients, persons with disabilities, the list goes on, but also faculty, students, and staff in those environments as well. And so in as much as I would like to wish that those circumstances didn't exist, I think we have a large degree of evidence that points to the ways in which they have persisted for hundreds of years.
Yeah, and I think there's like I said, coming back to some of my earlier comments around, there's an aspect of truth and reconciliation in that, in terms of just acknowledging that these things have happened.
Absolutely.
That health professionals and doctors in particular carry a certain amount of power. They're scientists, right? And we, as making decisions in our society, are seeking facts and evidence to support our decisions, whether whatever those policies might be. And so there's lots of examples. I think if we think carefully, even in the context of COVID, right, where it only takes the voice of one physician who said that that vaccinations are unproven and don't produce the right results, right, to be amplified and spread miraculously around the world. Which he doesn't speak for everybody, but somebody's going to say, but the doctor said.
Right. Yeah. And so it speaks really to the power that we have as professionals and have held over other populations. Often, I'm going to let my colleagues off the hook and say today's generations of physicians may not do that with intent, but I think the call now is that they have to do it with awareness. They have to be aware of the impact that they have and the impact of the power that they hold as professionals in communities, because, as you say, it can be so damaging and devastating.
Yeah, and I think it's that awareness that I think you've painted a wonderful picture of that, that in walking into that room, right, you carry with you that privilege or disadvantage, knowingly or unknowingly, and that creates a can create a power differential, I guess, in that conversation before it even starts.
That's right.
So my next question builds on a quote that I received in my own LinkedIn feed here this week that was quoting Dr. Natisha Massaquoi. I hope I pronounced her name right. It reads, when we're talking about health equity and the need for health equity, we're talking about the survival of Black people. It's not as simple as everybody receiving the same care regardless of race. And when I'm talking about health equity, I'm talking about a system that responds and wants Black people and Black communities to survive. So, I mean, there's a lot packed into those couple of sentences, I think. But the thing that I guess that really struck me in reading that is that it's not as simple as everybody receiving the same care regardless of race, which seems in some ways provocative, but I think also very insightful. But I guess I wanted to get your perspective on that, and maybe you could help unpack that and add your own perspective on that.
Yeah, gosh, there is a lot there. And I love the quote. Thank you for sharing it. I think it's absolutely accurate. And so I would say a few things. I guess I would say everybody receiving the same care suggests that everybody is already equally receiving some baseline level. And so everybody will kind of, if increases are made to that baseline, that everybody will continue to sort of have equal outcomes as a result. Mm-hmm. But the reality is that many of our patients are disadvantaged long before they set foot into our healthcare system. And so if we're going to create a disadvantage, for the purposes of their health outcomes. And we have all kinds of statistics that point to that, our chronic disease statistics, our premature death rate statistics, let alone our social determinants statistics around education levels and poverty levels and employment levels. The list goes on and on. So we have whole populations of people, including Black populations, as the author of this quote is pointing out, that are living with that level of disadvantage day after day after day. And so if we expect that by providing them with equal care to everybody else, they are going to reach an equal outcome to everybody else, we are mistaken, because what I describe is they are already starting with anchors on their feet. Mm-hmm. And so if the idea is to level up everybody, those populations we need to work with much more intensively in order for them to actually receive those same high-level outcomes that we expect everybody else to receive. And so there's that in the quote. I see that. I also see in the quote a real sort of call to inclusion. And I think, the notion of inclusivity is one that is a little bit more difficult for us to wrap our minds around. And I suspect that that's why the author is pointing to that specifically. This idea that we need a system that responds and wants Black people and Black communities to survive. And I would say other communities that are underrepresented as well, or equity deserving as well. And so it speaks to a number of things about, so how are those communities actually included in the healthcare system now? Who are the decision makers in the healthcare system? And are those decision makers representative of those communities and their ideas and needs? Who gets to decide? For me is always, I'm a public health physician, so for me it's always a public health question, but I would also say it's a health systems question, it's a medical education question that helps us uncover where are biases hiding in our decision making that might continue to exclude certain groups, again, from those outcomes that we espouse wanting them to have. And so it's a question of whether or not the decision makers at play truly represent the universal experience or truly understand a universal experience, or is the experience that they are expecting to interact with based on some normative, sort of set of conditions that those decision makers have not questioned or interrogated before now. One of the ways I put this, I've recently had a conversation with a colleague of mine here at Dalhousie University, and I tell this story quite frequently. Dr. Eli Manning is our visiting scholar in equity, diversity, and inclusion and accessibility here at the Faculty of Medicine. And that is a program that we deliberately set up to invite scholars from those other disciplines who know way more about the challenges of inequities than we do in medicine, to spend a year with us, helping our faculty sort of move these conversations along. And so when Dr. Manning first started, she and I had this fantastic conversation where she said to me, wow, you guys in medicine, you have this really interesting conceptualization of the model patient. And I knew it was going to be good. So I said, do tell me. And what she said was, well, in social work, which is her home faculty, when we talk about the model patient, we talk about the patient that we have to model our services after.
Mm-hmm.
And then she said, we know in social work that our patients are going to be from newcomer communities, they're going to be single moms, they're going to be from Indigenous communities. And so we model our services to make sure we're supporting that. And I started laughing. I said, oh, that is not our definition of the model patient in medicine. I said, we literally have a model patient that we use for teaching called the 70-kilogram man. And if you ask certainly faculty members of my generation, and I would suggest we are probably still teaching this to students, they will all recognize the 70-kilogram man. And so the mantra is, if you can understand physiology in a 70-kilogram man, you can understand it in anybody. Ouch. And then she started laughing because we both realized that in that conversation, we have not said 70-kilogram white man, but that's assumed. Mm-hmm. We have not said 70-kilogram white able-bodied man, but that's assumed. We have not said 70-kilogram white able-bodied cisgendered heterosexual man, but that's assumed. And then we were both in stitches because, I had this realization. What I said to her was, Eli, there's not one of us in our clinical practices that only has 70-kilogram white able-bodied cisgendered heterosexual men, right? So how is it that our systems are actually being designed for the people that really see them, that really need them? I think that's what your quote is calling to, Dale, around this question of, do we have a system that actually wants equity deserving groups to thrive? And if the answer to that is yes, then we would actually have to acknowledge the ways in which we may have designed systems that systematically exclude those groups because they're just not part of the frame of thinking, right?
Yeah. Yeah. So, you've come right into the next question I sort of wanted to come to you with as well. But I'm still sort of processing the brilliance of what you've shared. So one of the things that I'm really hoping to get through with the whole series that we're doing on EDI, but in particular in our conversation here today with you, is trying to understand the issues about institutional or structural racism. So I think it's some of those systems that you've just described in your final comments there. It's certainly well quoted, and it continues to be quoted. I just heard it a few weeks ago, again, from some of our, highly esteemed politicians or right, that, again, their words may not have been intended as such, but those sound bites persist, where they simply say there is not structural or institutional racism in our province or in our organization. Right. And I know when I'm saying this, I'm not asking you to agree or disagree with that. I think it's highly rhetorical, but I think really it is. So how do you answer that question, or that answer that he made? What is your perspective on structural racism, oppression? I think, as you would describe it even more broadly. How does it continue to persist in healthcare more specifically? I think you've alluded to a little bit of that in terms of medicine in particular. And then, I know this, in 10 words or less, how do we dismantle it?
Well, if I could do that in 10 words or less, I'd probably have a different job. Yeah, I mean, it's a good question. And although we're chuckling, I am aware that we both, kind of understand the ridiculousness of the statement. And so I would go in a few different directions, maybe with that idea. I mean, the description I've just given you of how the healthcare system has been created and with who in mind, I think is a really important one. And I don't think, in fact, I think there's ample evidence in the social science literature, as well as now increasingly in the medical education literature, and in the health outcomes literature, to point to the ways in which absolutely in healthcare we have structural and systemic racism. And why wouldn't we is the thing. So when I look as a public health physician into the determinants of health, which I describe as the large societal systems of influence that shape our everyday lives outside of the healthcare system, our systems of justice, education, social services, transportation, those types of systems. I'm aware that just like the healthcare system, those systems have been brought up under 400 years of false ideas around race. They were constructed from those same false beliefs around biological differences between people of different skin color that we now know not to be true. So I'm speaking specifically about racism, but I think similarly, my colleagues who come at it from a feminist theory perspective would say similarly, that has happened for the construction of women and their roles in many of these institutions as well. And so over 400 years, we have taken this false construct and we have continued to build on it into every single institution that has come since. And without, I don't think, being necessarily always conscious of how we were layering on to those false ideas. And so we now have these deeply embedded to the point where they are hidden from us. They are like the air that we breathe. They're just there. Ideas about who the systems are there to serve, who are the, I am saying who are the problems that the system needs to solve. So positioning certain populations as problems to be solved, to be dealt with, not as having inherent and intrinsic value to add to the system. That has been a construct over 400 years. And so you don't have to dig very far, and you don't have to have a history degree, in order to realize, holy cow, if that's been the construction of it, then how could we not have systemic oppression occurring in our institutions, right? So it's a little, I don't know, you use the term, I think, disingenuous, but I think it's a little naive. To insist that this doesn't exist when the entire world was constructed around these false ideas, right? And we are still living with those institutions today. And I recently, or about a year ago, actually reached out to the authors of the Implicit Bias book. Many of your listeners will be familiar with the implicit association test. And, like many who do this work, I am familiar with that work. And, one of the legacies, I think, of that 400 years of construction around this issue of race and the racism that we've been left with is that it now is embedded in our brains, right? So we have these beliefs in a place that we can't see. The whole point of an implicit bias is that it lives in the unconscious, which means that it's in a place in the brain where you can't access it and you can't alter it, which drives us crazy, right? Because we all wish we could just flip a switch and our brains wouldn't do that anymore. And then we could, sort of cleanly declare ourselves to be not racist. And the challenge is that none of us can make that declaration because we've all been brought up in this 400-year kind of fog. And so I wrote to the one of the authors of that test and one of the scholars in that area of work and said to him, so what do we do? He's a psychologist. I said, so how do we undo our brains from this place? And his answer was, you can't. What he said was, short of another 300 or 400 year social experiment where we deliberately, sort of flip the paradigms that have been created by where we've gone, we will not be able to undo the wiring in our brains, right? So again, I go, when that's at play, it's naive to think that it does not also play out in our institutions. And then when you look again at the social determinants of health and the health outcomes and social outcomes that we see as a result of that, you see that it is definitely playing out in our institutions. Statistically alone, we have the evidence of that in those outcomes around grade 12 graduation, incarceration rates, children in custody of the state, et cetera, right?
Yeah, and I guess as you're describing the challenge of sort of changing that, I guess the one thing that I was also thinking, like, you can't, I think it's a conversation I had with Dr. Gigi Osler as well, right? I mean, you can't leave your subjectivity behind. I mean, because it's part of who you are, right? So you cannot become overtly objective or neutral in some of these things, because there's all this stuff, as you well pointed out, right, that's wired into who we are. So I'm wondering about the connection between that then and empathy, or some other construct that we might use to somehow not rewire that, but somehow to still find ourselves in a space where we can still see others, see, I think, as you've described at the beginning as well, the unfairness or the inequities that are coming with people into their interactions with us, and meet and going back to the social work sort of paradigms, meeting them where they are as opposed to where we are. So does that resonate, or is there something else that you might add to that?
It really does. And I might add something else to it. I think it's empathy, but I think it's also something like critical self-awareness. So, I think the empathy is an important piece. And I'm aware that often when folks try and engage with empathy, they see it as something that I do for another. And while I think that's helpful, I think there's another layer to it, which is something that I recognize in and of myself that requires me to respond to another in a certain way. That's a little bit different framing. And so that's where I think the critical self-reflection comes in. So in order for us to extend that empathy, I think we have to really challenge ourselves to see how any of us might be upholding oppression in any given moment, including by the ways of the identities and therefore powers that we hold in any given moment, and then extend that empathy on the basis of that understanding. And that, I think that's true at an individual level, but I think it's also true at a systemic level. So I'm aware too, and the longer I sort of stay in my career as a physician, maybe the more critical I get of the system, because I'm aware that even in our best attempts at being patient-centered and empathetic and responsive, there is something about how we have oriented towards patient care that is suggestive, again, that the patients are a problem to be solved or a problem to be managed rather than having intrinsic value to the system. And that manifests in the ways that we have signs of welcome or don't in our facilities, for example, or the ways that we have rules and requirements and expectations in our facilities, but don't ask what might be expected of us in return, right? It can very quickly become a one-sided conversation with the healthcare system when a patient engages with the big amorphous 50% of provincial budgets or approaching 50% of provincial budgets healthcare system. And so I don't know how we reorient that, but as we reorient the self around empathy and critical self-reflection, I would wonder if we don't also pay attention to how the system then starts to portray something that we actually want to see, right? Every time I go into an acute care facility, I look around at the signage and the walls, which I think is a really good way of understanding the institutional orientation. I am struck by how directive and unfriendly a lot of that signage can be. Literally down to the point of do this, don't do that, don't do that, don't do that, or we won't provide care. And while I can appreciate that some of those messages, particularly around respectful behavior, need to be there, what I don't see is the promise that we're extending as well as healthcare systems, if our condition is met. And I think being able to extend that promise is really important. I speak to it frequently. And in the One Nova Scotia work that you referenced in my bio, I spoke to it around the concept of welcome, which is not a academically well-studied construct. There are a few academics around the world who have looked at the idea of welcome and what is intrinsic in a good welcome. But what they point to is when you get the welcome right, a whole bunch of other outcomes start to emerge. And in broadly speaking in community, some of those outcomes, so the literature that looks at welcome, for example, for immigrant populations into new communities points to that welcome leading to all kinds of outcomes, educational attainment, for example, civic engagement down the road, all those types of things. And so it makes me wonder, in our tiny little corner of the world in the healthcare system, what would extending a meaningful welcome unlock in terms of patient outcomes staff satisfaction, lowering of burnout rates. I think there's something more that we could be looking at there that allows us to be in more of a direct relationship with the communities that we're interested in than maybe we think we are right now.
Yeah, I'm sure that and I think it's another great place for us to look and examine, right? Because it goes unseen in many respects. It's just assumed, and I certainly reflect, like, it's just in terms of the interpersonal welcomes about how we present a hand, or right, those things, right, mean so much. But in an organization perspective, there's so many other symbols and signs, I guess, that sort of get communicated as part of that.
That's
which
right.
we never really examine. And I would reflect on even my interactions with my own local hospital of, going to an ER, right, to get service, and there's that line on that floor, and I think exactly you said, don't cross this line, and there's so many things that get caught up in that, but you're already in a place of being told, of distrust, of being creating power, right, threatened,
Yeah.
right, and I'm an able-bodied white man who's 70 kilograms, right, so
Right. Right.
right, and I feel uncomfortable there. So I can imagine, right, for many others, right, where those lines have had other symbolic meanings in their other places in their worlds, in their lives, right, that it just sets things up on the wrong foot, literally.
That's exactly it. That's exactly it. And all of a sudden, we're not in a collaborative relationship. We are in somewhat of an antagonistic one, whether or not we ever intended to go there, right?
Mm-hmm.
They're subtle structures, but I think they have more importance than we pay attention to. The one that I often use when I'm lecturing on this topic is the pride flag.
Mm-hmm.
And what I remind folks of is that you can walk down, certainly here in the city of Halifax, you can walk down any sort of street in the downtown core, and you will see many pride flags proudly displayed in shop windows. And every single person who walks by that flag knows what it means.
Mm-hmm.
They know that it means that if you come in here and you identify as part of the LGBTQ2SIA community, you will be welcome here and you will be protected.
Mm-hmm.
And I am willing to bet that not any of those shop owners went to a 1 day or 2 day or 2 week seminar on how to provide a welcome and safe environment before they put that flag up, right?
Yeah.
So there is something intrinsic about our knowledge of how to provide a welcome that doesn't require any training. It just requires a little bit of thought. I'm from the Maritimes. We all know how to provide a good welcome. We pride ourselves on it in the Maritimes. There's going to be lobster. There's probably going to be fiddle music somewhere. I mean, we just go there. And so, I start to think about if we could extend those types of promises, even subtly, by the use of symbols like that, what would it mean to those communities that we're trying to serve? The catch is, it is a promise. So if we just blindly kind of put up the symbol and then walk away from the obligations that it actually represents, the community will spot that in a heartbeat and they will call us out on it.
Yeah.
But I start to wonder, what are the ways that we could extend that welcome, right? And exactly as you said, which is a little, counter to the current messages that we are giving explicitly or subtly in our institutions.
So you've talked about sort of the need for critical self-reflection in this. So go, and I think perhaps weaving that back into the discussion previously around the structural and institutional side of things. So how do we gain that organizational self-reflection, and just sort of leading you a little bit, the role of data in that?
Yeah, well, I think data certainly plays a big role, and as a public health physician, I'm always going to go there. And one of the challenges in the Canadian healthcare system continues to be that we are not collecting differential data on outcomes for our Canadian healthcare system. Broadly speaking, it's happening in pockets. The government of Nova Scotia has committed to making race or ethnic identifier available at the time that somebody is issued a medical insurance card here. Which will be helpful, so that now there will be sort of that data point that the health system can enter into, and maybe then we can start tracking these outcomes. Because the challenge is, if we're not collecting the data, then we get to do two things. One is we can't see the problems that are occurring. We can't see the differentials in outcomes that are likely occurring. And so that means that we get to deny that there is a problem. And I recently gave some remarks in this area at University of Western Ontario, and one of the attendees pointed out that not only do we get to deny that there is a problem around our approaches to equity, but we also then get to make the claim that we're not like the United States. We don't have the problems that they have. So the United States, by contrast, does collect this data.
Mm-hmm.
The data does point in real time to strong evidence of differential outcomes for underrepresented and equity deserving groups. But because we're not collecting the data in Canada, what this participant was pointing out is that we've been standing in this place of we don't have those problems here, which feels a little bit like willful ignorance, right? It's easy for us to say we don't have the problems because we're not collecting the data. And so from my perspective, I think that that's actually critical. I was part of some of the conversations here in Nova Scotia and nationally about how we create data collection tools for COVID. To kickstart that conversation in Canada, my hope is I'm no longer in the public health system, but my hope is that work continues and extends out to other health outcomes beyond COVID, because we have to start looking at this. So I think that's a big one for sort of healthcare system leaders and healthcare institutions. And I would regularly get asked by my colleagues who are not in public health, but other parts of the healthcare system, what's the population health approach to successfully running a healthcare system? And what I would say is create the data. Who is coming in the doors of your institution? Who is not coming in the doors of your institution? And for those who are not, why not? And some of the answer might be they actually don't need the institutions, because many of our citizens, we forget, are hale and healthy and living their lives out there, and they don't need to come in the doors. But also be prepared for the ones who are not coming in because they do actually have a need, but they don't feel the health system can meet it, or there may be other reasons. You have to collect that data to understand the reasons before you can create a response to it. And in the absence of collecting that data, what we do is we create the response. People aren't coming in the door, so we need to do something. Let's go to that community and let's offer them a clinic. And I've literally been in communities where that has been done, and then nobody from the community came to the clinic. Mm-hmm. And the healthcare system said, where is everybody? Why haven't they shown up? And the community said, well, you're a healthcare system. You asked what you could do for us. We know you do clinics, so we said yes to that. But actually, what we need is education, jobs, access to clean water, those basic necessities, housing. And that's not something the healthcare system provides. But in the absence of data pointing to what are the actual issues in these communities, the healthcare system just went ahead and built a clinic, right? And so having that data is helpful for communities, but it's also helpful for the system to make sure that we're actually making the right diagnosis before we launch an intervention. That's really critical.
Yeah, I would agree with that. Certainly, I think if you're a hammer, right, you see everything as a nail. So if our system, sees itself as being a provision of health services, then it assumes that that's what it should be doing for all its communities. But right. So I'd love to get your perspective, and maybe data is connected to this as well, to be fair. So I'd love to get your perspective on the relationship between racial, ethnic, cultural discrimination, oppression, bias, and other kinds of mistreatment in the health system, and the relationship between that and harm. And especially as it relates to how that might be interpreted or labeled, in the context of patient safety. And maybe just to give a bit further context on that, I mean, do you think that this type of incident or situation should be treated as a formal patient safety incident, assuming that harm has occurred when someone experiences these kinds of situations?
Yeah, I mean, not surprisingly, my bias would be toward, I think it should be reported, because those systems exist as system learning opportunities. I say that knowing that one of the challenges is still in the realm of patient safety. I think we have many providers who don't see those systems as system learning opportunities. They see them as something else, something a little bit more punitive for the provider. And so there is hesitancy in engaging with those reporting systems from a provider perspective. There will also be hesitancy in engaging from the patient perspective. So we've spoken about the power dynamics that are at play when somebody from an equity deserving group engages with the healthcare system. And so the distrust of the system may be high, such that even getting the sort of report from a patient, even with the support of a healthcare provider, may be difficult to do. The patient may just want to walk away from it because they'll worry that by reporting it, it impacts their future care. I still think it's a worthy pursuit, because if we could generate those reports, then we're doing two things. One is we are providing those systems learning opportunities so institutions can do better. And the second is that if we are successfully generating those reports, then it probably means that somehow we have created a culture of welcome and safety in the institution so that patients now feel supported to report and are not afraid to do it. And that means we're doing something right. So whenever these types of questions come up, as they have even in our faculty of medicine here at Dalhousie, I'm always quick to point out to people that an increase in reporting does not necessarily mean the sky is falling. An
Yes.
increase in reporting might actually be might actually mean that the folks who are reporting trust us with the information. They trust us to see it and honor it, and they trust us to do something productive with it. And so if trust is going up and reporting is increasing, at least at the beginning of a reporting, sort of system, the early days of it, I think that's actually a really important marker. So I think there are a number of ways in which reporting mistreatment is really instructive. And yet, I have been in the rooms where not just providers, but, also health system administrators are wary of that type of system, because what if this gets out in the public? How do we tell the story? How do we make it seem like we're not a racist institution? And I think for those administrators, the dialogue probably needs to be something different. It's not about denying that you are racist, because as I think I've discussed already, how could any of us not be racist given the 400-year fog we've been living in? And so the question becomes, how does a system with integrity actually point to, yes, we see this data, yes, we believe in this data, yes, we know we have work to do, and here's the work that we're doing, and we'll keep doing it until we get it right, and we welcome more feedback. That's a different response, and I think one that would actually be met favorably by the media, as well as by the public at large. So that would be the example, I think, that I would encourage system administrators to set with that type of reporting.
Yeah. So, and it maybe bring this full circle again. It comes back to sort of acknowledging this is how we are, but we aspire to be different, right? To a different world.
Exactly.
So,
Exactly.
but you still have to acknowledge the harms, and right, and that can be painful. I can well assume, right? None of us very few of us go into this world intending to hurt others, right? That doesn't mean that we don't, right? So, and in healthcare, I think it certainly happens for sure. I mean, you've heard examples, I've heard examples, we've seen them, right, of people who've been treated inappropriately because of their race or gender, and that has left, a scar, right, had nothing to do with the real reason that they presented themselves. And how does one deal with that? So,
yeah, it's exactly that. And it comes back, I think, to your question of, these are the ways in which we start to understand it's not as simple as everybody receiving the same care, regardless of race, for example, or regardless of gender, or regardless of ability. It speaks to some much deeper soul searching that we need to do in our healthcare systems if we're truly going to provide the equitable care that we say we're interested in.
yeah, well, I know, for me, conversations like this with yourself are very, very enlightening and very empowering, quite frankly. And I don't think of myself as a racist person or part of the problem, but that doesn't change the fact that I still feel like I'm learning in my own way through this. And so I can't thank you enough for sharing in this, and helping me to better understand my own role in this, and how myself and my colleagues and others across the country can be difference makers in aspiring to something better.
It's a pleasure. Always happy to have the conversation and really glad for your interest in this question.
Great. Thank you, Gaynor. I wish you well. And yes, I do hope that we can have further conversations on this. I know you have many other insights to share as well. So thank you again.
My pleasure.
You've been listening to the HQ, and I'm Dale Sherbeck, your host. You can find this and other future episodes on the CHA Learning website, Apple Podcast, or Spotify. We'd love to hear what you think, so please follow us on our other social media channels. Thanks for joining us in this discussion today. Please join us next time.